Our next speaker is Professor Vitali Sinchenko. Professor Sinchenko is the director for the Center for Infectious Disease and Microbiology, Public Health at the University of Sydney. He's a leading public health pathology informatics person. He's a microbiologist, informatician, and conducts research on biosurveillance of communicable disease. Very pertinent topic in the COVID times we live in. Thanks, Vitali.
Thank you very much, Farah, for this kind introduction. It's pure delight to be here today and catch up with old friends and colleagues and reflect on amazing advances that CHI has, as a team, has made over the last 21 years. I recall the day when I saw Enrica first time, and Ross Lazarus from University of Sydney sent me to Enrica when I asked Ross about the best supervisor for my PhD in informatics at the time. Enrica was on his own in his office. It was early 1999, and things started really rapidly exploding from 2000, and I was sharing PhD office with Farah. So it's a lot of very happy memories. And today is an opportunity for me to talk about genomic surveillance. COVID-19 has been one of the examples of very disruptive events, even catastrophic events, if we reflect on message from DVCR. But this always has been a tremendous opportunity for researchers and clinicians. And I've been a microbiologist by training, and I remain a microbiologist. And obviously, I used to look at microscope a lot more than before than these days. But what Kai did, provided to me this macroscopy approach. I zoomed out from my little microscopic bugs to broader problems, to have a broader view, to focus on knowledge creation and sharing. This is how informatics was defined by Enrica at the time. And more specifically, on actionable knowledge discovery. Discovery of knowledge that makes difference in healthcare especially. So there are these knowledge structures that evolve over time, but increments, and we're really focused on delta I, making sure that delta I, this change in knowledge, is actionable, makes difference, and focusing on utility, because at the end of the day, structure of defining utility helps us to select what is actionable, what has a larger value. And it resonates very well with our current grant applications when you need to decide how to shape your grant application. We published several papers at the time about clinical decisions, about complexity of these clinical decisions, and how complexity theory can help us to choose the high value applications. I would like to use COVID-19 saga to illustrate the value of such approach. And this saga started in late 2019 when Eddie Holmes, a colleague of mine, professor of Genomics at the University of Sydney, tweeted the link in Virologica for the first genome of SARS-CoV-2 virus, which was recovered from a patient in Wuhan with this severe pneumonia. So this is a first presentation of this 30,000 bases, full genomic infrastructure, very detailed infrastructure, that describes spike protein and other structural and non-structural proteins and genes that are coding for them. And this genome allowed development of diagnostic assays and obviously sequencing assays as well. And we started receiving, collecting, and sharing a lot of genomic data. So USyd is a public database which was created for influenza virus, has been applied to collate genomic data for SARS-CoV-2, where consensus sequences have been uploaded together with minimum metadata, date of specimen collection, state of the origin of this sample, and submitting laboratory. And you can see that within weeks after initial announcement, hundreds and then thousands, tens of thousands, hundreds of thousands have been collected at exponential rate with more than 11 million submissions by July. So this has been unprecedented, where researchers, clinicians have shared that volume of genomic data and metadata willingly. The cost of this data is huge, coming close to $500 million now. And it's all in public domain. You can argue that a lot of the major beneficiaries have been Pfizer, Moderna, other companies that have been making huge inroads in creating new vaccines, new drugs, new treatments for this condition. But it also allowed, as an approach, to monitor in real time or near real time evolution of the virus. And this is a phylogenetic tree that represents the distance between sequences only, that shows the arrival and diversification of multiple sequences, starting with variants of concern, and a lot of variants of concern are too historical. So you can see delta at the bottom with some diversification in blue, and then these two bunches of gold looking omicrons that are becoming larger and larger, just reflecting the more and more sequences being done in different countries in the current time and submitting and being submitted to USyd database. So what we're observing really transition from databases, which has been under government control largely, to open science databases, where a lot more genomic data with metadata becoming available for reuse for secondary analyses. And this paper, published last month in Science, gives an example of application of AI to this data, to millions of SARS-CoV-2 genomes that have been deposited in USyd, NextStrain, GenBank. And machine learning trains the system to identify patterns of mutations that are associated with a higher fitness of the virus, more capacity to spread and cause symptomatic disease in individuals. So you can see over time how lineages, especially variants of concern, have emerged, and their relative fitness on a Y scale, and B Omicron variants, BA1, BA2, which are becoming less and less prevalent now in our communities, being replaced by BA4, BA5. You can argue this is a bit old news because things are changing so fast these days. But it's as good as it gets at the moment with the current system of publications, of analysis of data and publication in peer-reviewed journals. And scaling down to our own lab at Westmead Hospital, where we started sequencing in February 2020 with small number of genomes every week, and then going to kind of July 2021, after Bondi cluster of Delta virus and then arrival of Delta full scale and being replaced by Omicron, the number of sequencing runs and the number of genomes on every run have increased significantly, and this marked shift in the purpose and objectives of our surveillance. In the phase 1 of genomic surveillance, we were delivering detection of clusters, because at the time this is a value which our colleagues in public health, in clinics, in the government wanted the most. We identified genomic links for cases without links. We were providing information to the minister that we don't have any unlinked cases and border with Queensland can be open, etc. We resolved transmission chains, but what happened with Delta, the sheer volume of cases has become so large that referring laboratories, that diagnostic laboratories in private and public practice didn't have any capacity to refer samples anymore. They were completely overwhelmed. The system of surveillance has become struggling. And we switched to targeted and representative surveillance, to a very different mode, with objectives to sequence cases of severe disease that matters for clinicians. Focus on high-risk settings, focus on disadvantaged groups of patients, and identify drug resistance and identification of community outbreaks has become less relevant because we've experienced so many of them. So you can see that added value, this delta I, have been changing over time and quite rapidly over the course of this pandemic. And we were trying to address these changes in requirements as we go. We showed that genomic surveillance in the first phase made significant differences for public health. We managed to cluster cases in addition to epidemiologically defined links. We managed to improve clustering of locally acquired cases and reduce the number of cases without links, without good understanding of the origin of their disease. And imported cases without links have been managed better. We also produced some, as we felt, new tools of visualizing this population dynamics of the virus over time. We call it fish plot. So at the bottom you can see standard kind of epi curves, number of cases over time by epidemiological weeks, and you can see the first increase was in the first part of 2020, when we had a lot of cases imported from different parts of the world before the borders were closed in Australia. And on a fish plot, you have this structure that collates different colors. Each color represents individual clusters, and these clusters represent individual importations. So y-axis is a representation of a number of cases within each cluster, and epi weeks are time. And you can see that border closure pretty much removed all local transmissions in New South Wales. And then second wave was very much locally acquired infection. A lot of cases due to Delta, initially representing 2 or 3 clusters, 2 or 3 colors, then dominating with one color. Again, infection control measures, pharmaceutical, non-pharmaceutical interventions especially, took it to a halt. And our public health colleagues used this fish plots to understand better the dynamics over time, to see how much and in what direction public health measures affect the transmission of the virus in a community. Drug resistance detection has been another important dimension of genomic surveillance. You probably remember that this spike protein of the virus plays a key role in a cell entry into epithelial cell, and it connects to what we call receptor on an epithelial cell ACE2. And mutations in a spike protein can affect this interaction, of course. The trouble is that a lot of drugs that have been designed to control SARS-CoV-2 infection in humans are competitors for this ACE2 receptor. So they compete with spike. Mutations in spike change the equation and make drugs less efficient. Sotrovimab is one of monoclonal antibodies that have been designed specifically to prevent this interaction between spike and ACE2 receptor. What we managed to detect early on when Delta arrived is that Delta could accumulate gradually after exposure to sotrovimab mutations in this resistance binding domain of the S gene that codes for spike protein. And these mutations occurring after exposure to sotrovimab, which is a really one big infusion of monoclonal antibodies, and these mutations lead to change in viral yield, and eventually virus population becomes resistant and can survive in the presence of high doses of sotrovimab for a very long time and then propagate. So clearly, detection of drug resistance using genomics, verifying these mutations, has been important in the management of the cases of SARS-CoV-2 infection. Our genomic surveillance also has been important in identifying mixed infections, or co-infections with different variants at the same time. And it's just one example of a case from event that we identified in Sydney at the time when Delta and Omicron were present in the community at the same time. Renal dialysis unit, a very busy healthcare facility providing renal dialysis for people with end-stage renal disease 3 times a week, when they spend 4 or 5 hours in renal dialysis unit next to each other, taking some drinks, talking, having meals, etc. So this is really a place where exposure can happen. And because of sheer numbers of patients that required renal dialysis who were infected with COVID, they were cohorted together at the same time. And you can imagine that people with VOC Omicron and people with VOC Delta were sitting or lying next to each other. And sequencing of samples allowed to visualize these events. So this is just an example where day 1 you have positive PCR and you detect just Omicron, and then on day 3 you have a Delta signal being present, and day 11 is just largely Delta signal. And that was overwhelming for that particular immunosuppressed individual, and sotrovimab didn't make much difference because mutations were present. When to identify these co-infection events, you really need to have this very high resolution, very detailed genomic surveillance data. When you can look at across genome, you have to take genome-wide view and look at number of reads from next-generation sequencing machine present in different locations. And you can see reads that represent Omicron in yellow, reads that represent Delta in blue, and you can see that majority of marker mutations are present really in spike protein, in a spike gene, and this is well understandable. But you can also see that a majority of populations in that particular event are blue. So gradually, Delta overgrown Omicron in that particular host. So we created systems that picks up this mixed co-infection, and it was quite a revelation for us. But sharing, collating this data from consented individuals is not that straightforward. There are different types of sequencing files. Some of them represent input data, raw sequencing data, called FASTQ files, which we believe are property of our pathology providers that do sequencing. Some files are inference data, FASTA files, representing consensus genomes in different formats, and they need to be enriched by clinical and epidemiological metadata connected to these files. I would argue that this enrichment is really critical, and these phylogenetic trees with circular metadata representing particular identification numbers for clusters, the origin of these cases, which epidemiological event they've been associated with, are very important summary documents that are critical for epidemiological and clinical decision making. But when you think about the integration of this data into health records, into different information management systems, you need to appreciate differences between laboratory information management systems that keeps raw sequencing data, raw laboratory data, as well as metadata which are available to laboratories, from EHR that collects laboratory reports, not necessarily primary raw sequencing data, and public health information management systems that collect information on notifiable conditions, with different reports, not individual line listing reports necessarily, but aggregated reports with epidemiological context. And then there are biobanks, repositories that are becoming more and more popular because storage of data, storage of clinical material, storage of isolates, culture collections become more and more expensive. So everything, all of the above, or parts of this, can be provided to biobanks. And in open databases, we're very careful to disclose a lot of metadata detail without substantial governance arrangements, but raw sequences or consensus sequences, inference data, are present. So I've asked Enrico this question, is clinical genomics part of EHR? A lot of people in human genomic space believe that they should be integrated. We own our genomes. Do we own COVID-19 or SARS-CoV-2 genome? Do you own Mycobacterium tuberculosis or, God forbid, monkeypox genome, which is recovered from our clinical samples? The answer is not that obvious, and a lot of people, ethicists, lawyers, of course, are thinking about it. So the journey of SARS-CoV-2 has been really a revelation and huge opportunity, because in itself, SARS-CoV-2 is a catastrophe, is a big event that challenged the humanity, challenged our human societies. It's called now 16 trillion virus, $16 trillion virus. as a US assessment, 90% of the annual USA gross domestic product cost, just for one country. Transgenerational risks for sustainable development and WHO development goals have been really challenged. But when you think about added value and transitioning and evolving added value from high throughput, high resolution investigation of SARS-CoV-2, we started with the case definition confirmation, just confirming that cases that we had diagnosed in first days of the pandemic were truly SARS-CoV-2, not other virus. Then building real-time genomic surveillance and cluster detection system for 2020. And then understanding better tracking viral evolution and spread globally and locally, to more recent monitoring of viral escape, monitoring of drug resistance, persistent infections, and we're talking a lot about recurrent infection with COVID, understanding long COVID, and designing of vaccines, designing of new drugs with higher value and higher level aim to develop a scalable, sustainable system for pandemic control, ecosystem of sharing the data, looking at data and reusing the data. Thank you very much for your attention. I would like to thank at the end our fantastic team that have been working on in microbial genomics space at Westmead. I think Carl is here in the audience, and I think Rosie has returned to Kai in one kind of incarnation, I suppose. Rosie did a PhD here. So we have this close alumni links that we hope to develop further, foster further, because there is a growing overlap in our joint interests. Thank you.